I would like also to welcome Dr. Dina Nabil Abbas, pain management consultant at Saudi German Hospital Group and professor of pain management at National Cancer Institute in Egypt, Cairo University, and the co-founder of the Egyptian Society of Pain Management. Tonight's webinar is going to discuss the continuum of pain management, including a talk for Dr. Dina Abbas for integrated approach in pain management, and a talk for Dr. Adil about the role of non-steroidal anti-inflammatory drugs in pain management. Each talk will take like 30 minutes. It will follow by questions and answers. Please forward your questions at the question and answer page, so we'll be able to raise it to the our speakers and panelists at the after the talk, at the end of their talk. Tonight's webinar is accredited by 2 hours CME hours. All our participants who is going to register and attend the webinar and using their Saudi Commission for Health Specialty registration number, they were going to be they will get 2 hours CME will be uploaded to their account. There will be also a feedback questionnaire at the end of the webinar. We'll appreciate if you all completed and sent it to be able to get your electronic certificate and CME accreditation. I want to thank all of our participants, all of our guest speakers, and I hope that you'll enjoy this webinar and it will be fruitful for all of you. I would like to invite Dr. Dina Nabil Abbas to start her first talk about the integrated approach in pain management. Dr. Dina, please.
Thank you, Dr. Yasser. And thank you, Dr. Adil, for accepting our invitation. Bismillah ar-Rahman ar-Rahim. My talk about integrative approach for pain management. I have no conflict of interest. The ILOs of my lecture will be about types of pain, the burden of chronic pain, results of early intervention in management of pain, the concept of pain management. First, I'd like to define who is pain physician. This question, we are constantly asked about this. Pain physician is a physician with special training in evaluation, diagnosis, and the treatment of all types of pain. He has in-depth knowledge of the physiology of pain, and he has the skills to perform procedures and prescribe complex drugs. He can coordinate additional care with other physicians in multidisciplinary approach like physical therapy, psychological specialist, rehabilitation program. What is pain? The International Association of Study of Pain defined pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage, and specify this year, 2020, to be the global year for prevention of pain, with 3 goals: to protect against the onset of pain, and this is primary prevention, and to prevent pain from becoming chronic, and this is secondary prevention, and reduce the long-term consequences of pain, and this is tertiary prevention. What are the types of pain? Pain can be classified according to the etiology, to cancer pain, back pain, according to the cause of pain, or according to the onset of pain, acute or chronic, or according to mechanism involved, nociceptive or neuropathic, or according to the tissue involved, somatic or visceral. The burden of chronic pain. Chronic pain carries great economic costs. These costs include healthcare and medication, absenteeism from work, income loss, loss of productivity, financial burden on family, friends, and employers, social and compensation costs. Chronic pain affects all aspects of daily life. That is why the WHO notes that chronic pain should be accepted as a condition by its own right and highlights the great burden of chronic pain. Unmanaged acute pain like post-surgical pain, post-operative pain, acute onset of back pain, inflammatory pain due, example, post-herpetic neuralgia. All these leads to activation of nociceptor fibers. Sustained activation due to untreated such conditions lead to what is called CNS or central neural plasticity, and acute pain become chronic pain. Under treatment of acute pain may predispose to persistent pain due to neuronal plasticity and CNS changes, resulting in symptoms of neuropathic pain. These symptoms are very variable, from numbness, tingling, electric shocks, sensitivity to touch. A group of symptoms, GIT symptoms, difficulty walking, all these we should be aware of. Speaking about the most common cause of patients to ask medical advice, low back pain. Low back pain is the first cause since 1990 until now. This is a study done in 188 countries to study the incidence, prevalence of back pain, acute and chronic, and still we say that low back pain is number one. After all this advancement of surgery and the technology, still back pain is number one. There must be a problem. Why back pain is still number one? There is bad management in the doctors or something in diagnosis. We should look carefully and review all facilities we have. Pain is a physiological symptom. It cannot be photographed or biopsied. We are not treating radiology. We cannot depend on MRI, because if we have done MRI for asymptomatic patients, we'll find more than 50% will have disc problems without complaining. So MRI is not conclusive. This study, large study in multi-center, shows that patients who are operated upon, the result is the same like patients who are not operated upon. So surgery is not important, because at the end, both are the same results. What can low back pain cause? Low back pain can cause cascade of events ending with what is called central reorganization, changes at the level of the spinal cord and the brain. This study shows that early intervention for back pain can prevent pain from becoming a chronic. Results of early intervention, it decreases the indices of chronic disability, which range from absence from work, healthcare utilization, medical uses of drugs. This is a scenario we have every day. 55 years old man come complaining of severe pain at low back region with burning sensation and tingling sensation in his right leg for 3 years. He is depressed. He cannot attend his job. He had laminectomy, discectomy, and transpedicular fixation for his back pain due to intervertebral disc prolapse. This scenario we find every day in our clinics. Can we avoid this problem? Yes, by simple intervention, we may avoid surgery. This study shows that epidural steroid and transforaminal injection can avoid surgery, and this is an evidence-based review and protect against unwanted surgery by simple injection. Again, this is the NICE guidelines recommend that management of back pain to be in the form of self-management, exercise, psychological intervention, together with radiofrequency, and spinal surgery come late and in selected indication, and recommend against spinal fusion or disc replacement for management of low back pain. Again, there is a consensus few months ago from multi-speciality recommend the use of radiofrequency for lumbar facet joint pain, and this can avoid unnecessary surgery and decrease the suffering of patients from surgery. By simple intervention can be done fluoroscopic guidance or by use of radiofrequency machine to target selected nerve and do ablation for that nerve. This may avoid unnecessary surgery. Again, second cause for patient to ask for medical advice, knee osteoarthritis. It is a problem to many patients worldwide. This should be treated in a multimodal and multidisciplinary approach. This is the rheumatology recommendation for management of joint pain, knee pain, for example, to use exercise, weight loss, and self-management, and added radiofrequency recommended in certain conditions. This may avoid unnecessary surgery. This is another scenario for a patient, 54 years old, referred to pain clinic. He has 2 months of right-sided neck pain radiating to his shoulder and lateral forearm and index. Plain X-rays show degenerative facet predominantly at C3. This patient was managed by paracetamol and non-steroidal and was advised to wear neck collar and to do physiotherapy, but he cannot tolerate to do the physiotherapy due to pain. Interlaminar cervical epidural had play a role and cause the patient to tolerate to do physiotherapy by simple intervention done under fluoroscopy. Another scenario of patients who came to pain clinic, an 83 years old male has severe burning and stabbing pain across the right shoulder wall. He had history of shingles 4 months ago, but now the lesion disappeared and the skin is just sensitive and the patient had pain. He rarely leaves the house. Examination revealed hypopigmented patches in T4-5 dermatome together with in the area of herpes zoster infection. This is the skin lesion. You may find this skin lesion disappeared, but still the patient can feel burning pain. If you are not aware about this problem, the patient may suffer, and his pain become chronic. What is called post-herpetic neuralgia. The skin lesion may disappear, but the patient still suffer from severe burning and neuropathic pain. We should be aware of such cases. And such cases should be referred from the dermatology and managed in an multidisciplinary approach. Case 3 of a female had right extremity pain with swollen, discolored limb. She had lost considerable movement of her forearm, wrist, and hand. The patient had her arm in a protective manner. She has numbness, paresthesia in the hand and forearm, and she is sensitive to touch, temperature changes. She gave a history of carpal tunnel syndrome 4 months ago. What is this case? This is a challenging case. If we are not keeping it in mind, this patient may continue asking medical advice at many clinics. Again, this is 35 years old male attended to the pain clinic suffering from burning pain in the whole right upper extremity. The pain increased with cold air and the pain is felt on touch. He had history of fracture of right wrist, which is healed with closed reduction and immobilization, but still there is pain. This is picture of a swollen limb, and the patient is asking medical advice. If you are not keeping this case in mind, what is called complex regional pain syndrome, and this is another picture after carpal tunnel repair and after arthroscopy for knee. These are the continuum of suffering of a patient of complex regional pain syndrome. He sought medical advice at the orthopedic, at the emergency service, at the rheumatology, physiotherapy, occupational medicine. He asked medical advice in all these. If we can avoid such suffering by keeping in mind this challenging condition and managing it early, we may help this patient. What is complex regional pain syndrome? It is a complex of dynamic presentation with genetic predisposition. This doesn't occur to all patients. This is regional. It doesn't obey the dermatome distribution, and the pain is out of proportional to the causative event, and it is a syndrome of symptoms and signs. Another case scenario of a female patient. She has right mastectomy and had post-operative radiotherapy 10 years ago. Then after 10 years, she started to feel pain and asked for medical advice. Although metastatic workup was done and she is free. She has post-irradiation pain. That pain may come after 10 years after the radiation. All such scenario may benefit from what is called sympathetic blocks. Sympathetic blocks, simple procedure, can help patients with neuropathic pain, with visceral pain. with vascular disease. Example for vascular insufficiency, Raynaud disease, scleroderma, vasospasm, peripheral occlusive disease, either of upper or lower limb, or painful syndromes like complex regional pain syndrome, like vascular headache, acute herpes zoster and post-herpetic neuralgia, phantom pain, Paget disease, neoplastic disease, post-radiation neuritis, intractable angina, diabetic neuropathy, and the pain due to cranial nerves involvement. All these painful conditions can benefit from sympathetic blocks, either stellate ganglion block or lumbar sympathetic, with good evidence. This intervention has good evidence and can help and terminate patient suffering. This is lumbar sympathetic chain done under fluoroscopy. Another case scenario for 55 years male known to have cancer pancreas, referred to our clinic, suffering from severe epigastric and right hypochondrial pain radiating to his back. The patient is on tramadol 100 milligram per day. He suffers from constipation. The patient is leaning forward and unable to sleep. Celiac plexus block was done to him and opioid rotation and dose adjustment with good response regarding not only to the pain, but sleep and quality of life. Opioids are the mainstay for cancer pain management. But unfortunately, cancer pain is not properly managed and is under treatment due to fear of using opioid. This study studying the effect of celiac plexus block on patients with cancer pancreas on the quality of life. It showed that patients who received celiac plexus block established low pain scores and better quality of life. This is another case scenario for a patient with cancer cervix on 60 milligram morphine sulfate tablet twice daily, and she had superior hypogastric plexus block, one of the sympathetic blocks, with partial improvement. What to do? This is superior hypogastric plexus block done under fluoroscopy. This is the AB view and this is the lateral view. For such a case, we don't say that intervention is magic. We have to adjust the dose of opioid due to different types of pain that cancer patient has. This is the European Society of Management of Cancer recommendation that recommends that pain management should be started early in any management plan for cancer patient. Analgesic drugs are only one part of cancer pain management. There should be an integrated approach for cancer pain management, including anti-tumor treatment, chemotherapy, surgery, radiotherapy, together with interventional analgesic drugs and rehabilitation intervention and psychological support. All these should be done together for a patient with cancer. Another problem, the specialty of pain physician can help headache and facial pain due to migraine or trigeminal neuralgia or many causes of headache and facial pain. The specialty of pain physician can help. Examples of intervention to be done for a headache and facial pain: trigeminal ganglion block, sphenopalatine ganglion block, occipital nerve block, cervical blocks, trigger point injection. This fluoroscopic view for trigeminal ganglion block for a patient suffering from trigeminal neuralgia. The ideal approach for pain management to be multimodal, multidisciplinary, and in a continuum. What multidisciplinary mean? Many specialties should cooperate to treat patient and terminate his suffering as possible as we can. Starting from the nurses, they play an important role. Social assessment, medication, pain psychologists, pain physiotherapists, and the pain specialists can coordinate all these specialties. The management should be multimodal: pharmacotherapy, manual therapy, physiotherapy, interventional nerve block, individual psychotherapy, and the prevention is the best. If we can prevent this pain by early management of acute pain, this is the best approach. Multimodal analgesic drugs acting on all areas of pain pathways by different drugs, by different modes of intervention. Multimodal approach for chronic pain management, we should do definitive therapy, treatment of the cause if we can, pharmacotherapy, interventional approaches, physical therapy, psychological therapy, and the complementary medicine. All these should cooperate together to try to terminate patient suffering. We have the WHO ladder, which was introduced very long time ago by step 1, step 2, and step 3, starting from non-steroidal, analgesic, and non-opioid, then weak opioid, then strong opioid. But this has changed. But unfortunately, not all are aware of that. There is a fourth step which introduced to this step ladder, which is a nerve block, epidural, PCA, neurolytic block, spinal stimulation. And this ladder is bi-directional. We may start with step number 4. It is not all necessarily to start step 1, then step 2, then step 3. It should be bi-directional. We can start in any step according to the severity of pain. We shouldn't let the patient suffer, and we will say you are keeping only on non-steroidal. If the patient has severe pain, we may start with the intervention together with the drugs in step 3, according to the severity of the pain and to the pathophysiology of pain. It should be tailored to each patient. Management of pain should be in a continuum, not in a step ladder. We can start at different starting point. We can use multiple therapies at the same time. To avoid chronic pain syndrome, which is a constellation of syndromes that usually don't respond to the medical model of care. There is no one model fit all patients. This condition should be managed with multidisciplinary approach, requiring good integration of knowledge and the multiple organ system. Recently, there is approach for pain management, it is multimodal approach and the tailored therapy for pain management. It is called trolley analgesic model. This is recently introduced. As pain is dynamic, so not every scenario or management fit all patients. We can start with opioid, we can start with physiotherapy, we can do all together, we can open one drawer and then close it. So the management should be tailored according to each patient, according to each disease, to each stage of therapy. So our recommendation to always consider the intensity of pain, the pathophysiology of pain, the complexity of symptoms, the presence of comorbidity, the social context, and the time of illness. We have to rethink about the concept of pain. We can play an important role. We can be a hero and to prevent unwanted neuroplastic changes in patient life. Every one of us can share in this. And the pain management, usually he is aware of aware of patient suffering. At last, I always try to think and remind myself and my colleagues, as long as you feel pain, you are alive. As long as you feel pain of others, you are human. I hope that all pain physicians and all specialties be a human and think of patient pain. So our hearts need to be soft enough to feel the pain of others and strong enough to care about it. Thank you.
Thank you very much, Professor Dina, for the very informative lecture and explaining the important role of pain management in modern medical care and the different modalities that could be used to reduce patient suffering and improve outcome of our care. I want now to invite and to welcome our main guest speaker, Dr. Adil Kamal, pain management consultant from King Faisal Specialist Hospital, is going to talk about the role of non-steroidal inflammatory drugs in pain management. I would like to welcome Dr. Adil for his talk. Now, as we said, we have many questions was raised for Dr. Dina, and I'm sure there will be as many also for Dr. Adil. We are going to start the question and answer session after we finish with Dr. Adil's talk. Mr. Raisa, maybe unmute Dr. Adil, please. And
Thank you for unmuting. I was trying to signal that I am muted. I need to be unmuted. Dr. Adina, kindly unshare so I can share my slides. Thank you, Dr. Adina and Dr. Yasser, for the invitation. I would like to welcome all our audiences tonight. I hope this is going to be informative for all. Today, I had the easy job of discussing non-steroidal anti-inflammatory medications. It is one of the most common drugs that we are using in our medical practice by various specialties. I'll start off with just a bit of history about non-steroidals and when did we start using them. Hippocrates, who lived between 460 to 377 BC, and he was actually named the father of modern medicine. He was the first person to report the analgesic properties of willow bark. Willow bark بالعربي is شجر الصفصاف. And he reported the analgesic properties of the leaves of willow bark. And since then, it has been used for its analgesic properties until 1827, when Jonathan Buchner isolated the active ingredient of willow bark, which named salicin. About 40 years later, the chemist by the name of Herman Kloeb synthesized salicylate, which is we're still using until now in the form of aspirin acetyl salicylic acid. But aspirin as aspirin was not manufactured until 1897 by Felix Hoffman. The other non-steroidals followed since the 50s. Started with ibuprofen, followed by Voltaren, and thereafter the other non-steroidals. So since the manufacturing of non-steroidals have been used for its analgesic properties, but it was also used for its antipyretic and anti-inflammatory effect. Regarding inflammation, once we have tissue injury, that would lead to release of a lot of inflammatory mediators like bradykinin, substance P, prostaglandin. Prostaglandin is synthesized from arachidonic acid by the function of the cyclooxygenase. The cyclooxygenase enzyme is what is the target enzyme that non-steroidals work on. Once prostaglandin is synthesized, they bind to the cell membrane of nerve fibers, and that lead to sensitization of those nerve fibers, and that would lead to propagation and transmission of the painful impulses. The inflammatory process leads to the formation of the 5 cardinal signs of inflammation: hitness, redness, swelling, pain, and loss of function in some occasions. So cyclooxygenase is the enzyme that works on arachidonic acid to form prostaglandins. And in medical practice, the majority of us are aware of the 2 types of cyclooxygenases, COX-1 and COX-2. COX-1 is mostly responsible for the physiologic process, which is the gastroprotective effect and platelet activities, while COX-2 is mostly responsible for the inflammatory process. We're talking about fever and pain. A third type of cyclooxygenase was described in 2002, and I have the reference in the bottom of the slide. And the third type is proposed to have the central mechanism of analgesic and antipyretic effect of non-steroidals and other medications. So there are 3 different types: 2 peripheral, 1 central. The central is responsible for the effect of the NSAIDs and COX-2 inhibitors on the antipyretic effect of those medication, including even paracetamol, and that's how paracetamol or acetaminophen exerts its antipyretic effect centrally. When we give non-steroidals, the non-steroidals will inhibit prostaglandin synthesis by the action of the cyclooxygenases and inhibiting cyclooxygenase, and therefore that would inhibit the release of prostaglandin, and therefore it reduces pain perception in by that sense. NSAIDs are rapidly absorbed in the gut. There's almost complete absorption of those non-steroidals. There is a limited tissue distribution, so there's no fat or muscle deposition. It's actually excreted almost in the same amount that it was taken after it's being metabolized by the liver and excreted by the gut. The toxicity of non-steroidals is related to its half-life. So the longer the half-life, the more toxic it is, roughly. Not a solid rule for all non-steroidals, but to give you an example, the half-life of ibuprofen is 2 hours. So it is one of the lower toxic drugs. There is different response to different non-steroidals. So if you try one non-steroidal and it doesn't work in a patient, you can certainly try the next one and the next one and the next one, because a resistance to one non-steroidal does not necessarily mean that the patient will be resistant to all non-steroidals, provided that there is no contraindication of trying different non-steroidals. The most toxic non-steroidal described in the literature is indomethacin, and there is one clinical use that so far is indomethacin is being used so far, and that is patent ductus arteriosus, treatment of that. and the least toxics are ibuprofen and salicylate. Now, when we measure the potency of medications, we always talk about NNTs, or numbers needed to treat. And the definition of numbers needed to treat is basically the number of patients that would experience analgesia if they received an average dose of a medication. What does that mean? For example, the morphine that we measure most of the drugs, most of the other analgesic to, the numbers needed to treat for morphine is 1. And that means that every single patient that we give morphine to will experience at least 50% of pain relief. When the number NNT is 2, 1 in 2 will experience analgesia. If the number is 5, that means 1 in 5 will experience analgesia. So the higher the number, the weaker the medication. The smaller the number, the more potent the medication. And if you look to the screen on the left, valdecoxib, which is Bextra, which is non-steroidal, it's available in the Saudi market. Its NNT is about 1.5 to 2. So 1 in 2 patients who receive valdecoxib will experience at least 50% of pain relief. Celebrex, again, is 2 to 3. So 1 in 2 to 1 in 3 people who uses Celebrex 400 milligrams per day will experience some analgesia. Tylenol number 4, which is paracetamol and codeine, the numbers needed to treat is 2 to 3. If you look at tramadol 100 milligrams, the NNT for tramadol in the bottom of the left slide of the left graph, the numbers needed to treat for tramadol is 4 to 6. So that means at 1 in 4 or 1 in 6 people would experience some analgesia if you give them tramadol. If you look to the right side of the screen, the combinations, for example, ibuprofen and paracetamol combination will give you a similar analgesic effect compared to valdecoxib. So we were talking, and we will continue to talk about multimodal analgesia. And multimodal analgesia means that you use more than one drug to treat pain, and here, or more than one technique to treat pain. And that's what when we mean when we say multimodal. And here is the best example on the right side. Combinations of medications can give you really good analgesia. These graphs are taken from the Cochrane data, which is the British data collection site or bank. So this is the Cochrane Reviews data. Of course, we've been talking about multimodal analgesia, and non-steroidals, including even COX-2 inhibitors, work on the pain pathway all the way from the periphery to the central effect. As we said, when we have tissue injury, that would lead to release of inflammatory mediators, and that would lead to propagation of painful impulses through the A, delta, and C fibers to the spinal cord, and then through the spinothalamic tract and reticular formation all the way to the brain. And the main concept of analgesia is preventing that impulse from reaching the brain. And we use multi-techniques to avoid that painful impulses from arriving to the brain. Non-steroidals and COX-2 inhibitors do work on several parts of this pathway to help reduce pain. I'm not gonna give you a headache by many studies. I just wanted to share with you this meta-analysis, which was released in 2005. The authors reviewed more than 50 articles with a total number of patients close to 5,000 patients. And they wanted to compare analgesia with acetaminophen, non-steroidals, COX-2 inhibitors, and PCA, patient-controlled analgesia with morphine compared to morphine alone. And certainly, the notice that the regular use of morphine, like patient-controlled analgesia, is associated with less consumption of morphine. So regular dosing is better than PRN dosing. But what is related to our talk today is the effect of COX-2 and NSAIDs. For example, rofecoxib, which is Vioxx, was associated with more than 50% reduction in the amount of morphine used So it was very helpful as a multimodal analgesia, but it was withdrawn because of its effect on the heart. And we'll talk about that in a minute. Non-steroidals, conventional non-steroidals reduced morphine use by 40%. Other coxib reduced morphine use by 25%. Paracetamol reduced morphine use by 20%. So if you combine paracetamol and non-steroidal, you end up with at least 50 to 60% reduction of morphine use. So again, we're talking about multimodal analgesia and how useful and important it is. One of the other clinical uses of non-steroidals is actually protection against cancer, and it's mostly associated with colon cancer, especially in familial adenomatous polyposis, or polyps of the colon. That is a familial disease, and to prevent it, they start the patient on aspirin, but in fact, you can start the patient on other non-steroidals, even COX-2 inhibitors like Celebrex. And that was in a study this was published in the year 2000 in the New England Journal of Medicine, and it was associated with significant reduction of cancerous formation of the polyps, up to 30% in size and the number. So it is being used clinically to prevent some types of cancer, not all types of cancer. But of course, like any other medication, those medications are associated with significant toxicities. And one of the most common one is gastrointestinal toxicity. Dyspepsia occurs in about 50 to 60% of patients, even with use for as short of a period as 3 days. So a lot of patients, even with using non-steroidal for only 3 to 4 days, they might end up with dyspepsia. GI bleeding is also a risk, or a perforation, especially in elderly patients who are older than 60, or patients with peptic ulcer disease, or using steroids, or using alcohol, or even if you're using multiple non-steroidals, you are subjecting the patient to a higher risk of GI bleed and perforation. Enteric coating has a limited success in preventing this GI toxicity, but I guess it just makes the doctors and patients feel better about using enteric coating, but it is not proven scientifically to prevent the side effects, because remember, it is not the direct physical contact of non-steroidals with the stomach lining, but it's actually the circulating non-steroidal that can cause the harm. Antacids like Mylanta or Maalox or Gaviscon, they actually don't help. In fact, they might make it worse, because those antacids contain magnesium, and magnesium makes the ulceration worse. So if you have a patient complaining of dyspepsia or gastric ulcers due to non-steroidals, don't give them antacid, because it can actually make it worse. What helps is the H2 blockers, like I know ranitidine now is out of the market, but you can use cimetidine, and that is good for treatment, not prevention. If you would like to prevent, if you have a patient on chronic non-steroidals, H2 blockers are not going to be helpful. Cimetidine will not be helpful. What's going to be helpful is proton pump inhibitors like Losic or Nexium. Those can be very helpful in preventing gastrointestinal side effects, but of course they're a bit expensive, more expensive than the H2 blockers. And one of their side effects is diarrhea. The other side effect for these non-steroidals is platelet inhibition, and platelet inhibition happens with all conventional non-steroidals, but not the COX-2 inhibitors. COX-2 inhibitors do not cause platelet inhibition. They can cause gastrointestinal upset, they can cause renal impairment, but they do not cause platelet inhibition. The platelet inhibition is reversible for the conventional non-steroidals, and it's related to the half-life. I would remind you again with the ibuprofen. The ibuprofen half-life is 2 hours, so if you stop it for 4 to 5 half-lives, or 8 to 10 hours, it will be completely out of the system. It would be okay. It will not cause platelet inhibition after the 8 to 10 hours, except for aspirin, which causes irreversible irreversible platelet inhibition. Remember, aspirin half-life is 36 hours, and if you count 4 to 5 half-lives, we're talking about 6 to 7 days. But actually, for platelet functions to go back to normal, you need at least 6 to 8 days, because that is not because the aspirin will be dissociating from the platelets, but actually you're waiting for new platelets to be formed by the bone marrow. So aspirin causes irreversible platelet inhibition. In a meta-analysis regarding the other one of the potential side effects, especially with COX-2 inhibitors, is cardiovascular side effects. And in this meta-analysis, which was published in 2006, and in fact here the author collected more than 70 different articles regarding the use of COX-2 inhibitors and the risk associated with that of various COX-2 inhibitors. And there was a definite increase in the risk of MI and vascular events in patients using COX-2 inhibitors compared to placebo. In the same article, he reported that most of the cardiovascular side effect occurred with rofecoxib. Again, remind you about rofecoxib. It's Vioxx, and Vioxx is off the market since 2009 or 8, I guess. Sorry, so I think it's earlier 2000. Vioxx was stopped. The one after that can really cause cardiovascular manifestation is naproxen, especially if you are going to use more than 1,000 milligram per day. Naproxen can cause significant cardiovascular problems, followed by Voltaren. And according to this meta-analysis, using Celebrex or celecoxib, it was not associated with an increased risk compared to Voltaren or naproxen or Vioxx. And to explain why is that, why would naproxen be more harmful than Voltaren? You just have to remember that all conventional non-steroidals, they have action on both COX-1 and COX-2. Drugs with more COX-1 inhibition, they cause mostly the gastrointestinal manifestations, and drugs with more COX-2 inhibition, so theoretically they might be safer, they are more associated with cardiovascular manifestations. And the top 3 conventional NSAIDs that has more COX-2 inhibition compared to the COX-1 inhibition are meloxicam or Mobic, followed by naproxen, and then Voltaren. So those 3 medications, they do have an effect on COX-2 inhibition, but they also have an inhibition on COX-1. But the drugs like aspirin or piroxicam or indomethacin, they have more COX-1 compared to the COX-2. In the same meta-analysis, the author suggested that drugs with more COX-1 inhibition have more gastrointestinal toxicity, while drugs with more COX-2 inhibition are associated with more cardiac and vascular toxicity. But in a more recent meta-analysis, which was published in 2017 in the Journal of Clinical Pharmacology, Pharmacy and Therapeutics, again, the author reviewed articles up to 2017 regarding the use of non-steroidals and the risk of inducing cardiovascular manifestation. And according to the most recent meta-analysis, the cardiovascular adverse effect may not be based on the COX-2 selectivity, which contradicts the previous meta-analysis. Vioxx or rofecoxib is associated with the highest incidence of cardiovascular, but again, to remind you, it's off the market. Other COXIBs demonstrated no difference compared to placebo when it comes to non-steroidal side effects. Celebrex actually had lower risk of cardiovascular according to the latest meta-analysis, which goes with the previous meta-analysis. Renal toxicity is one of the issues also, namely the non-steroidals can cause decrease in renal blood flow, which can lead to ischemia. And that can lead, of course, either to water and electrolyte absorption increase, which can antagonize the antihypertensive effect of therapy, leading to hypertension and worsening of CHF. Acute tubular necrosis and renal failure can happen with an overdose of nonsteroidals. When you get an overdose of nonsteroidals, they are highly protein bound. Therefore, it's very difficult to dialyze them. Another precaution about using nonsteroidals is the use of nonsteroidals in asthma. And in this study, the study was established, a study on stable asthmatics given Voltaren or diclofenac, and the authors measured PEFR and FEV1 pre and post administration, and they found definite reduction in the values of the tests, but the values reduction was not more than 15%. Therefore, they concluded, despite the theoretical risk of using nonsteroidals in asthmatic, it would be an acceptable thing to do. Now to individual drug, I'm not going to talk about everything. I'm just going to talk about paracetamol, ketorolac, and COX-2 inhibitors. Acetaminophen is the #1 used drug all over the world. Everybody have used acetaminophen once or twice in their life, at least. It was historically it was thought it exerts its antipyretic and analgesic effect through an unknown mechanism. But now we know that it works on the COX-3 enzyme inhibition. One of the points that I wanted to draw your attention to, there is a ceiling effect for acetaminophen analgesic effect. There is a ceiling effect at 650. Toxicity is increased by drinking alcohol. This is the study which was published in 2003 regarding the maximum dose of acetaminophen. And in this study, they concluded that there was no significant clinical difference between using 650 compared to 1,000 milligrams of acetaminophen. So using 2 tablets of 500 milligrams of acetaminophen makes no difference than using 2 tablets of 325. Ketorolac is a potent intravenous analgesic as compared to morphine. 30 milligrams is comparable to 10 milligrams of morphine. It is one of the available intravenous medication. I'm sorry, I'm going to speed up because I'm running out of time. There are several intravenous nonsteroidals available in the market. Ketorolac is one of them. We also have lornoxicam or Zifo in the Saudi market. And over the last 3 years, we also had ibuprofen intravenously. So you can use that as a potent non-steroidal intravenously. COX-2 inhibitors, they're getting a wide use recently, or not recently, over the last 15 or 20 years. One of the formulation available is also intravenously. Dinostat is available. These are some of the recommended dosages for COX-2 inhibitors. Celebrex 200 to 400 milligrams per day. Dinostat 40 milligrams maximum per day. Arcoxia or enterocoxib maximum 120 milligrams per day. Those are the 3 COX-2 inhibitors available in the Saudi market. So I strongly recommend that you be familiar with the dosing. Contraindication of COX-2 inhibitors, pregnancy, lactation, and age less than 16, sulfur allergy, patient with angioedema or allergy, patient with cabbage, patient with previous history of heart disease or GI bleed, or renal or hepatic insufficiency. Now, to the next 3 slides are just summary of of how to clinically use nonsteroidals. I'm going to skip this. This slide just show you how strong of an evidence that we have about using acetaminophen for mild to moderate pain. Ibuprofen and naproxen are good first-line agents to start. COX-2 and other nonsteroidals would be the second line after that. And we have a grade A evidence about those 3 things. And because for the sake of time, I'm just going to skip the rest of the slide. So if we are planning to do or give a nonsteroidal, is a nonsteroidal needed or not? Is there inflammation or not? If there is no inflammation and the nonsteroidal is not needed to use non-pharmacological or other analgesics. But if yes, is nonsteroidal contraindicated because of renal insufficiency or gastric GI problem? If the answer is yes, then use NSAID or use non-pharmacological. But if the answer is no, you have to ask yourself if there is a risk of GI bleeding. If the answer is no, then use any classical NSAID. If the answer is yes, use COX-2 inhibitors. And the final question you have to ask for yourself is the patient is at increased risk of cardiovascular event. If the answer is no, then go ahead and select NSAID based on the gastrointestinal risk. And if the answer is yes, you should avoid non-steroidal or COX-2 inhibitor altogether. Last couple of slides, we are in the COVID time, and the WHO just issued this report after reviewing all studies that came out regarding use of non-steroidals in COVID-19 patients. There are more than 73 studies that the WHO reviewed, and there was some limitation to those studies, but the conclusion that there was no evidence, there is no evidence that non-steroidal will have a negative adverse effect on patients with COVID-19. So you can use non-steroidal to decrease the temperature or whatever you need to use the NSAIDs for. With this slide, I am done. Thank you very much.
Thank you very much, Dr. Adel, for the very informative and very comprehensive talk. I would like to open the floor now for the question and answers. We have many questions from our audience. Dr. Dina and Dr. Adel to answer them or to reflect on them or to comment. I'll start now, maybe, yes, by some questions. Maybe that's for Dr. Yes. We can start with Dr. Adel.
Sure.
Yes. Hello, good evening, doctor. Regarding using COX-2 inhibitors and other analgesics, how can we prevent renal damage when using this analgesia in long-term users?
Of course, a baseline renal function is recommended, and then frequent. There is no certain or specific thing you can do or a specific medication to guarantee that you are protecting your kidney. I think just simply clinical follow-up, periodic renal profile, and compare that to the baseline every 6 months to a year. I do every 6 months actually when I start my patients on non-steroidals or COX-2 inhibitors. Encourage the patient to have healthy kidneys as much as possible, so drinking plenty of fluid and making sure that the renals are washed regularly, but there's no specific medication that we give to protect the kidney.
Thank you, bro. Dr. Dina, what do you do to prevent post-herpetic neuralgia in practice?
Actually, to start management of neuropathic pain aggressively, because it is mentioned that neuropathic pain is a medical emergency. So I use multiple drugs, including anti-neuropathic drugs, and escalate the dose and increase the dose, balancing between side effects and efficacy. Together with the sympathetic blocks, it has good evidence according to the distribution of pain. I'll use intervention like sympathetic blocks, stellate, or thoracic according to the distribution of dermatome affected.
Excellent. Doctor, we have also, yes, please, Dr. Adel, go ahead.
Early antiviral therapy. So patients should not neglect, if they start to have a skin rash, early starting antiviral therapy, and maybe even early start of membrane stabilizers, like gabapentin, for example. That can certainly reduce the sequence or the duration of pain if it's going to develop. So early intervention is always the key, early treatment.
Sure. We have a question from Dr. Mustafa Shuaib, Dr. Dina, our group medical governance director. He's asking, patient with low back pain, significant nerve compression, sensory loss, and motor compromise, when would you send him to surgeon?
Actually, if there is motor affection or sphincteric affection, I'll send him to surgery.
Sure. Okay. Dr. Dina, also, do you do trigeminal ganglion block in AGH? And what approach you are using?
Trigeminal, according to the pain, which nerve is affected.
But he is asking if you are doing this procedure in our setting in Saudi German Hospital.
Yes. Yes,
Okay,
I can do it.
What kind of technique you are using, or
through
approach?
Guided through foramen ovale by radio frequency and stimulation to induce the patient pain. The patient should be cooperative, and if he senses that pain, we will do ablation to that nerve.
Okay, so for Dr. Adel, they are asking about any effect of non-steroidal anti-inflammatory drug on GSPD patients.
G6SPD.
Yes, G6PD.
Or حمى الفول.
Yes.
I honestly, I haven't seen patients in the last 20 years in my pain clinic with G6PD. Theoretically, they might induce, aspirin especially might induce G6PD. So it's preferable to avoid it. But in all honesty, I haven't seen one in my clinic that I had. I haven't seen a patient with G6PD in my clinic. So I don't know.
Okay. Doctor, what about using of omeprazole may be helpful when using non-steroidal anti-inflammatory drugs?
Absolutely. As I mentioned, the PPIs, proton pump inhibitors, omeprazole or Nexium, both are very helpful in preventing the development of gastrointestinal manifestations due to chronic use of non-steroidals. H2 blockers like cimetidine or ranitidine or sucralfate that we use quite often in ICU, they're good for treatment, but they're not good for prevention. So proton pump inhibitors are very good for prevention, yes.
Okay. There is another question also about Celebrex 200 milligram use or role in COVID-19 treatment.
As I mentioned, with the WHO meta-analysis release that was about a month ago or 5 weeks ago, they concluded that they're both non-steroidals and COX-2 inhibitors are not associated with any adverse sequelae to the use. So yes, you can.
Okay, doctor, what is the safest non-steroidal anti-inflammatory in pregnancy and lactation? Another question.
None, because especially in the third trimester, using non-steroidals is proven to be harmful. So it's a class D, I believe, C or D in pregnancy, because using non-steroidals in the third trimester of pregnancy is associated with patent ductus arteriosus. So it is not advisable to use non-steroidal in the pregnancy, except sometimes the gynecologists use aspirin for certain diseases to help the pregnancy continue. So in those situations, they give very low dose aspirin. It's not for a conventional use of non-steroidals for pain, if you will. They use 81 milligram for those diseases. The short answer is none of the non-steroidals is okay to use in pregnancy.
Thank you. Dr. Dina, they are asking about best pain therapy post-operatively, especially for surgeries with severe pain as hemorrhoidectomy.
Actually, the treatment also is multimodal and preventive in the form of non-steroidal, opioid, and regional anesthesia. All can help to decrease the post-operative pain.
Excellent. Dr. Adil, can asthma patients take non-steroidal anti-inflammatory?
As I mentioned, there was a study, and there is a reduction in FEV1, which was only 15% before and after using the Voltaren. And the conclusion of that study was it would be okay to use non-steroidals, but of course with caution. Use a small dose, less frequent than usual. You have to be alert and vigilant about potential harmful effect. Although the study concluded that yes, you can use, and I've known or seen many asthmatic patients who were started on non-steroidals and they continued using it for years after that without any exacerbation of their asthmatic attacks. But we always have to remember that patients are different, and you always have this one patient who might be more sensitive to these opioids, to these non-steroidals compared to the other. So the short answer is yes, and the long answer is yes with caution.
Yeah, the same maybe question related about how much percent of asthmatic patients develop the attacks of asthma when used non-steroidal orally?
Depends, not all of them, certainly. Not all of them develop an attack. I don't have the numbers on my head now, but certainly not a very high dose. Usually, those are a group of patients with asthma associated with nasal polyps. Asthmatic patients who have more attacks of nasal polyps, those are the ones that are mostly susceptible to develop asthmatic attack when you use non-steroidals. Other exercise-induced asthma or asthmatics or very mild asthmatics, and they're not associated with nasal polyps, they usually don't develop asthmatic attacks. So it depends on the patient.
Okay. Dr. Dina, there is one of our nurses asking about the health teaching we can give to a patient who just underwent nerve blocks or other pain management procedures as outpatient. Do we restrict the patient from bending or lifting heavy objects?
Yes, it is preferably the patient can avoid heavy work for sometimes, and we give him instruction to follow in his life to avoid the back pain. I think she's speaking about back pain, but most of interventions can be done as outpatient procedure, and the patient can do his daily activity and can be discharged from the hospital 2 to 3 hours after the block is done. But generally, the patient should avoid we can say unhealthy posture and lifting heavy objects that can cause back pain.
Sure. Doctor, there is a question, I don't know who should, maybe Dr. Adil, talking about 50-year-old with no significant chronic diseases, suffers from recurrent headaches, relieved by ibuprofen 600. Is there any measures of prophylaxis could be used?
It depends
to avoid complications, for example, hydration or other measures?
Well, it depends on the type of headache. If it's just simple headache, it's not migraine, if it's not cluster or tension headache, and the patient was seen and evaluated by our ENT colleagues, and it's not a sinus problem, and it's not an eye problem, it's not an ear problem. So all causes of headache were excluded, and this is just simply a simple recurrent headache that is being relieved by analgesics. Certainly, a healthy lifestyle is recommended. So walking and exercising and drinking plenty of water, all simple health maintenance measures can certainly reduce the attacks. Of course, if the person is stressed and they get the headache because of that, some lifestyle adjustment or even exercises like biofeedback exercise to personally self-relief of their tension by practicing mental exercises, all those can help. But if the patient have to have these analgesics, the ibuprofen, daily, for example, depending on the dose that the patient is using, if the patient is using the maximum dose of ibuprofen for a short period of time is 10 milligram per kilo TID with a maximum of 800 milligram per day for a short-term use. For a long-term use, we recommend to reduce it to 600 milligrams TID. And if your patient is using that high of a dose, then certainly using PPIs is recommended, like omeprazole or Nexium. Drinking enough fluid, monitoring your renal functions, things like that. But if you're using one ibuprofen every 2 to 3 days, that would be reasonable. I don't think that is associated with major side effects.
What is the best painkiller in gouty arthritis?
For me or for Dr. Adina?
Whoever, Dr. Adil, Dr. Dina.
As Dr. Medina mentioned, the step ladder of management of pain, of course, gouty arthritis is associated with higher level of uric acid. So treating the underlying cause, treating gout itself by using medication that will help reduce the level of uric acid is important. Exercises, especially if the patient is suffering from foot pain or whatever like that, things like that, certainly aquatherapy or simply walking in the water can help. I'm saying walking, not swimming. Walking in the water can certainly help with the symptoms of arthritis, whether it's gouty arthritis or osteoarthritis, whatever type of arthritis, knees or foot or legs. Aquatherapy certainly can be very helpful. But if you have to use medication after using the anti-gout medication, then non-steroidals would be a very reasonable thing to do.
Sure. Doctor, is there any safest non-steroidal either with dialysis patient or chronic renal diseases?
Actually, there are two different approaches. Some nephrologists say, well, the damage has been done on the kidney, therefore you can use non-steroidal. But remember, I mentioned that non-steroidals are very protein bound, so they are difficult to dialyze. So they tend to accumulate in the body, and that can cause further harm, like gastrointestinal and platelet inhibition, because even with the dialysis, you're not getting rid of the medication. The other school says, well, this is really harmful on the kidneys, so therefore do not use any drug that can cause further harm, because although the kidney is damaged, it can cause maybe more damage to the kidneys, but accumulation of the medication per se in the system, because the body is not getting rid of it, can cause other side effects to the body, like gastrointestinal problems. So I'm with the school who doesn't. So I don't use non-steroidals in renal failure.
Yeah. Dr. Adil, Dr. Dina, we have like 42 questions, more questions is coming. I think we are going to forward this question to you, maybe if you don't mind, just if we can answer them after the session, because I think we are coming to the end of our today's webinar. There are many questions about migraine, about migranil, for example. Is it recommended? Can we answer that in the like 5, 6 questions, maybe more 4 questions more about the for recurrent attacks of migraine? What about the drug called migranil?
Actually, migraine should be managed in cooperation with the neurology doctor and according to the patient, the starting dose according to the dynamic of to the history. So not all patients are fitted with the same drug. The drugs has rule, alternative drugs has rules, intervention, Botox injection, all play a role which should be tailored to each patient individual.
Okay, Dr. Adil, last question. Can ibuprofen used with paracetamol together?
Yes, absolutely, yes.
Sure.
Because they have 2 different modes of action. Therefore, as a part of multimodal approach, we do use combination of intravenous paracetamol and intravenous non-steroidal, or if the patient taking oral, then we give them oral. So absolutely, using paracetamol and ibuprofen together is recommended for moderate pain, because I was showing in the slide the NNT for the combination is about 1.5 to 2. So it's actually comparable to some pretty potent analgesics. So yes, definitely recommended. But of course, you have to stick to the recommended dose. As I was mentioning, there is no point of using more than 650 milligrams of paracetamol per dose. So 2 to 3 tablets of 500 is not going to be useful. It's only going to be harmful to your body because you're going toward the toxic dose. And ibuprofen, as I was mentioning, for a short period of time, 10 milligram per kilo per dose TID, maximum 800 milligrams per dose. So if you restrict 400 or 600 of ibuprofen with 650 of paracetamol, it will be very, very good analgesic, provided that there is no contraindication to using either. That means there is no liver disease, no kidney disease, no gastrointestinal problems.
Excellent. Dr. Adel, we have, Dr. Dina, we have many requests asking to have like a PDF copy of the presentation. Is it possible to do that to some of our audience?
We'll try to do that. Knowledge is meant to be shared, not to be kept.
Appreciating. Thank you very much. Thank you very much. Really, because I found many really, they are asking, it looks like they are excited about the information they had, and they want to have it as a reference in their practice or in their daily care.
Sharing knowledge. We are in the age of sharing knowledge. This webinar is a good example of sharing knowledge. It is not meant to be kept in books. It is meant to be taught and shared and spread, so people would have more awareness and more and people, medical practitioners can help more patients by having this knowledge. Personally, I feel, okay all the time about sharing my slides with people because it's about spreading the knowledge.
Sure, and we want to thank you personally and on behalf of Saudi German Hospital Group, really for your participation and very exciting and comprehensive and informative lecture. And I want to also thank Dr. Dina really for her approach to pain management and to reduce suffering of patients and improving outcome. And I believe many now of physicians and clinicians, they will change. Maybe there is the way maybe they approach the patient to more multidisciplinary and interdisciplinary approach to patient involving pain management in our medical care. And I want also to inform all our participants that CME will be uploaded to your account with maximum 4 to 5 days, but you have to make sure that you provided your email, your mobile number, and your Saudi Commission registration number, so we'll be able to upload your name, and if we have any problem, we can contact you for any further information. I want to thank all of you for attending our webinar today, and I want to give the floor also to Dr. Adel and Dr. Dina for the last word and the take-home message. Can we start by Dr. Dina, ladies first?
Thank you for such webinar. I want to spread the knowledge that we all should work together to give better services to our patient and to terminate patient suffering and improve the quality of life of our patient. Really, we feel very happy and very proud when we help patient, and thanks from patient means a lot to us.
Thank you, Dr. Adel.
I would like to thank you personally, Dr. Yasser and Dr. Adina, for the invitation. I enjoyed being with you. I'm glad that we had almost more than 800 participants, almost 850, which is great. I'm glad that I had the chance to share some of the information that I have. I hope I can be, I hope I was helpful and I was not ضيف ثقيل على الأودينس.
بالعكس يا دكتور، ده أنت شرفتنا ونورتنا، وإن شاء الله إحنا looking forward to more to come إن شاء الله.
الله يحفظك. Thank you very much. جزاكم الله خير. It's all about patient care and patient management. We are all in the medical field to look after our patients, and I'm glad that we are trying to be a small part of the whole system of trying to be helpful